Hello and welcome to Ruins on the Hill Media, where forgotten and neglected truths are unearthed. And welcome to this video about bipolar disorder, and by extension, we'll talk a little bit about depression. I'm going to try to keep this video to about half an hour, that way it's not too long. And so, my name is Greg Hamilton. I'm a licensed professional clinical counselor in the state of Ohio, and I've been working in the mental health field since 1989. And so I want to use this time to clear up some misunderstandings about bipolar. I noticed on YouTube there's a number of homemade videos regarding bipolar disorder, so I would encourage you, if you're interested in the topic and dealing with it, that you watch a bunch of these videos, see what you can get out of them. I don't know how good the others are, so I'm going to do my best to make this one good. And so my goal is, like I said, to clear up some misunderstandings as well. Just some things I've heard over the years that really concern me about the diagnosing of bipolar disorder. And so my audience is anyone who's interested in the topic. I am a Christian, but I'm not going to be sharing anything specifically of a Christian nature, belief system, anything really out of the Bible in this video. So this should be fine for everybody. I'm not going to scare anybody away with any specifically Christian stuff in this video. And so I am not a psychologist. I am not a doctor. I am not a psychiatrist. So I am not licensed to prescribe medication at all. I can't make recommendations for medication or anything like that. What I am licensed to do in the state of Ohio is to diagnose. So I can diagnose mental and emotional disorders. I often do that on my own. I often do that in consultation with other professionals. And so that's really important just to understand the whole medication realm. I can't really speak too much to that part of bipolar. I have worked with a lot of people over the years who, and by the way, the drum set is something I'll use towards the end of the video to just make an illustration that I think will help kind of bring my point home. And so, in the course of my career, I've worked with everybody, I've worked with just about every type of person out there, over the years, in every kind of setting. Practically, probably the only setting I haven't really worked in is a hospital setting, though I've worked in what we call partial hospitalization setting. And over the years, I must say, I've not really diagnosed too many people myself with bipolar. It doesn't come up I can't say it comes up frequently. However, I've had people come to me many people who have already been diagnosed with bipolar by somebody else, somebody in the past or somebody else that they're working with. And so I do believe there is an overdiagnosing of bipolar, especially in children today. And just by way of observation, there's the local children's hospital has been known amongst people at the agency that I work for. And, I've observed this myself and other professionals have observed it, but it seems like practically all, not all, but practically all the kids that are coming out of the psychiatric unit are diagnosed with bipolar disorder. And so that just that can't be right. It just can't be right. And I think, so one of the things I'll be talking about is why bipolar is misdiagnosed. And so when people come to me and I ask them, so has anyone ever sat down with you and thoroughly discussed, with bipolar, thoroughly discussed the symptoms, which means thoroughly discussing the symptoms of a major depressive episode and thoroughly discussing with them the symptoms of a manic episode. I can't tell you how many people have said to me, no one's ever done that with me. So that's another concern that I have. I think there's some diagnosing going on out there. It's being done secondhand. It's being done maybe through someone who knows the person, and often that is a parent or a close family member. But it's alarming to me how many people have not had a mental health provider or a doctor actually sit down and talk with them about the symptoms. And so I try to do that. I try to do that every time, because I just can't sit with the idea that I'm allowing a diagnosis to continue in my clinical records, and I haven't even talked to the person about it. So it's really important that patients and clients have direct input into the diagnosing process. And so that leads right into probably one of the most important points with this video, and that is that, if you and I look at all the diagnoses, and if you look at the DSM-5, which is the latest diagnostic and statistical manual of the APA, which is the American Psychiatric Association, the DSM-5 has all of the mental and emotional disorders listed with full explanations, and it has the list of symptoms that a person has to be exhibiting. So I want you as a mental health consumer, so to speak, to know that we all could look at a bunch of these diagnoses, and just looking at them on a cursory level, we would think, oh, I've got ADHD. Oh, I've got depression. It's easy to just diagnose ourselves when we just look at, oh, that symptom, that describes me, that must be me. And then we kind of get down about feeling like we have 20 different diagnoses, and it's like overwhelming. So here's something really important for you. And if you've been diagnosed with bipolar and no one has really talked with you directly, that's really important. What also is really important, that when you sit down with a clinician, when you sit down with a doctor or a therapist, psychologist, what they're going to be looking for is not only are you experiencing a certain number of symptoms, they're going to be looking at the question whether you've experienced these symptoms for a certain length of time. And so that is really, really important to know, because, again, I can have a little bit of trouble with my mood. I can feel down sometimes, but I believe the minimum time period for a major depressive episode to meet 5 out of the 9, I think it's 5 out of the 9 symptoms. It's 4 or 5, pretty sure it's 5, is to meet those criteria for 2 weeks, to have those symptoms for 2 weeks uninterrupted. So it's really super important with all of the diagnoses in the DSM-4, in the DSM-5, that, sorry, I was trained on the DSM-4, so that a person has to meet those criteria for a length of time. The next thing is, not only do they have to meet a certain number of them for a certain length of time, but it has to also, there's 2 more, so let me get to this one first. We have to be able to indicate and show and prove that the symptoms you're experiencing are not being experienced for any other reason. And so, in other words, if someone says, yeah, I've been feeling down, having trouble eating, we need to make sure that they're not having trouble with their thyroid gland, or we need to make sure that it isn't just the stresses of life that are affecting them in such a way that they're feeling down, they're having trouble eating, maybe they're having trouble sleeping, but maybe not for a full 2 weeks, or not significantly for a full 2 weeks. And so it's just super, super important. Every time I sit down with someone and talk through all the symptoms with them, with each symptom, I if they say yes to it, and they say, yeah, that describes me, and they say yes to the time period, and then the last criteria is it has to be of a certain intensity, enough to be interfering with the person's day-to-day functioning significantly. So if they say yes to that too, I need to make sure that it's not happening because of some other reason. Somebody can be grieving and they lost a loved one and they're definitely feeling down and they're definitely having trouble sleeping and stuff. But I might not diagnose a major depression or major depressive disorder because they're able to function, they're getting out of bed, they're going to work. Yeah, they're struggling, but they are able to function. So I want to be careful that I'm not giving them a label that could stick with them for a long time when really that label might not really be truly indicative of an actual biochemically based disorder. So that's the question. Is the symptom there because of a biochemical issue? Or is the symptom there for some other reason, including some other medical condition? All right, so those are all really super important. Like I said, the last one on that list was the intensity of the symptoms. I know that I have some trouble with attention at times. I have some trouble with being fidgety. You can probably tell a little bit just from the video even. But, the question there for me is, I guess I could diagnose myself with ADHD, but do the symptoms that I have really interfere with my day-to-day functioning, even if they did meet the other criteria? And for me, the answer to that question is no. I'm able to function. I'm able to do things. I'm able to stay focused on the things that I need to and want to. I'm able to finish projects, although I do often start projects and I don't finish them. I come back to them again, and some people would say, well, you're very distractible. Again, I do have that symptom, but I don't think that it really interferes enough to indicate that I need treatment or need medication, And there's a lot of people out there like that, even with mood issues. And so those are the things that we really look at as clinicians, okay? If no one has really slowed down enough to ask those questions in regards to your symptoms, then I would encourage you very strongly to go back to the person who diagnosed you, or find someone new and go through the process with them. All right? Now, the next thing that I want to clear up with bipolar is that when I ask someone who's been diagnosed, I say, why do you think you've been diagnosed with bipolar? I can't tell you how many times people have said something to me about anger being, I've had trouble with my anger, I have trouble with my temper, and I lose my temper really quickly and easily. My anger is explosive, and I go off on people verbally, or maybe they get aggressive, maybe they throw things. Maybe they just get so angry that they see red, or have a blackout of some kind. So if you look at the symptoms for depression, there's nothing listed pertaining to anger per se, really at all, as far as depression. And then if you look at the symptoms for a manic episode, there's also nothing there that has to do with explosive anger. And so this is really concerning to me when I meet with people and they say, I know I'm bipolar because I lose my temper really quickly. Well, that is not bipolar. Bipolar is two extremes of mood. Yes, anger can be an extreme, but in this case, it's depression. I think most people are familiar with, have an idea of what depression can feel like on some level. But the other extreme is not anger. The other extreme is the manic phase. And the manic symptoms are the opposite of depression. The person who's manic has a high level of energy. Mania can look sometimes a lot like the hyperactivity associated with ADHD. They have racing thoughts. Their thoughts are jumping around. They have what we call an inflated view of themselves. This is what we call grandiosity, or feeling like they are the best thing ever, and they feel like they're 10 feet tall and bulletproof. And so they tend to be awake for a number of days, or they need very, very little sleep, and when they wake up after an hour of sleep, they feel refreshed and they're ready to go again. This person maybe can't stop talking. They engage in really impulsive, high-risk behaviors without second thought. They get really focused on doing an activity, really, really focused on doing an activity, and maybe they do it over and over again. Maybe they clean their house from top to bottom in a space of about 2 hours, then they do it again, and then they do it again. So it's like, that's what describes mania. not issues with anger. So I want to clear that up. If you've been diagnosed with bipolar because you have anger issues, I would seriously encourage you to keep exploring what's really going on apart from a bipolar, because you may not have bipolar disorder. And so my next point is that with bipolar being diagnosed too frequently, I think, especially in children, and let's face it, it's an easy label. If a person's reactive and moody and up and down in their mood all the time, and they seem to be crying one minute and just bouncing off the walls the next minute, it is easy to just throw a label on them and then kind of throw a pill at that problem. I mean, let's face it, that is part of the world we live in today. Is let's identify the problem on a medical level so that we can throw a pill at it. I'm not saying that there are not people out there who genuinely need medication for mood issues. There are people who genuinely and very much need appropriate medication. But again, I'm just saying I think there's an overdiagnosis. And one of the reasons I think that is that, well, I mentioned trauma. So one of the things that can happen is that if someone experiences a trauma, it could be through abuse, it could be through a traumatic car accident or a soldier coming home from the battlefield or anything like that, that these people are often diagnosable with PTSD, which is post-traumatic stress disorder. And when someone has PTSD or some version of it or some lesser version of it, their nervous system has been put on high alert. It's like red alert. Remember the old Star Trek show back from the 1960s, red alert, whoop, whoop. It's like, this alarm system has gone off in their body and it hasn't turned off. So people who have PTSD or they've been through trauma and I say their nervous system has been activated, kind of awakened excessively. These are people who tend to be very edgy and on high alert for danger. They tend to be very reactive. When I say edgy, they just, they react to things much more quickly and intensely. And so their mood can obviously is going to also go along with times when their body is getting really, really worked up. Their nervous system is really getting agitated because of some kind of trigger in their environment, something that's setting them off. And so these are people who are going to look kind of manic sometimes. And then when the situation kind of resolves, they may go into some depression. And often it is depression that is very much related to the trauma, and maybe they're not thinking about the trauma, but it's there on a subconscious level. So their mood is still reacting to the trauma. And so I guess what I'm saying is people who have a trauma history are often going to look bipolar. I have found that usually when someone has PTSD or they've been through trauma, the manic symptoms of bipolar are really their nervous system being on edge and being very reactive. But they often do have a legitimate struggle with legitimate depression, and they often do need help medication-wise with depression. Again, some people with trauma also are truly bipolar, but I think that's one of the ways in which bipolar gets overdiagnosed, is because the manic, what people are labeling as manic, is really what they're seeing is the person's PTSD. Okay, so that being said, I think a lot of people also have been diagnosed with bipolar. What I would call it, and this isn't in the DSM-5, okay, so bipolar disorder, we sometimes shorten it to BD. I have my own personal little label called BHD, and BHD is broken heart disorder, And here's what I mean by that. There's a lot of people in this world who have been through a lot of crap, and they've been through some trauma. They've been through some major loss. And it just seems to me, and the people I've worked with over the years, that Yes, you can have somebody coming from a stable background, somebody who comes from a quote unquote good family, a family that truly is emotionally stable. People are not abusive, calling names and stuff, but they're emotionally, behaviorally healthy and stable. There are people who still end up with a true bipolar disorder, even though it might not run in the family, and we can't say that their environment or their family dynamics have really played any huge part in the development of bipolar disorder. But what I have noticed is that it does seem like people who have grown up in homes where there's been a lot of conflict, a lot of maybe there's been significant financial distress. There's a lot of fighting and name calling, a lot of drama, as we say nowadays. Maybe they've grown up with as a child of divorce, and the divorce was nasty, and they were there to see it. Maybe there's been domestic violence in the home. Maybe there's been drug and alcohol abuse in the home. Maybe there's been actual physical, emotional, sexual abuse in the home. Maybe they've moved around a lot. Maybe there's just been a lot of broken promises. Maybe just a lot of unstable relationships in general. Maybe after the divorce and they're living with mom, maybe mom has 10 boyfriends in 10 years, and it's just been very chaotic and very unstable for that child. And so someone who grows up in that environment, that too, even apart from actual abuse, a lot of times people are going to exhibit just instability of emotion, instability in their thoughts and in their moods and in their behaviors. And it's kind of like garbage in, garbage out. I think we're all, as children, it's like our hearts are like dry sponges. I'm actually going to do a separate video on that topic. And we just absorb the chaos and the negativity and the drama and the pain and all this stuff. So by the time someone becomes a teenager and a young adult and they end up in the mental health system, a lot of times they're being diagnosed with bipolar disorder because it just feels, their life and their moods just feel very chaotic and up and down. And, again, they may struggle legitimately with some actual depression, but the manic stuff, again, can be more about their personality and how their personality has developed. The manic stuff can be more about how they've learned to react to things, and maybe these are the people who are being diagnosed because of their anger problems, and they've had a lot of losses in their life, so they've developed anger issues because they've never been able to process their pain and their hurt and their loss. So again, I think that this type of person is someone who is more easily diagnosed with bipolar when many times it's not bipolar. It's more just how their environment has shaped them and molded them. Now, one of the things I try to do as a clinician and working with people, especially if I'm going to work with them long term, is I'm going to try my best to help them get stable in these different areas of their life, financially, relationally, maybe academically. I mean, all these different areas where things have been kind of crazy, so that I can see if after things get stable, so that I can see if their mood gets stable. I'm trying to see, okay, do they really have a mood disorder, or is their mood doing what it's doing because of their situation and their environment and their upbringing? So that's what I call broken heart disorder. Just a lot of stuff that can look like bipolar. All right. Now, that being said, it is true that if a human brain is under severe stress and distress for a long period of time, and someone starts to, quote unquote, act depressed, initially we might say, well, that person's just acting, they're just trying to get attention, and they're just kind of, manipulating others with their mood to try to get what they want. Well, that can be true. We all have to do things to try to get our needs met. And by the way, bipolar is often diagnosed when the real issue is drug and alcohol issues. clear up the drug and alcohol issues and the mood issues go away. So, somebody who, hold on just a second. Sorry about that. So someone who is acting depressed, that could have a lot to do with how they got their needs met growing up or how they were trying to get their needs met. And over a period of time, if they were not actually born with a genetically based, biochemically based mood disorder, they can develop one. If you act depressed and think depressed long enough, eventually you're going to have major depression, and it's going to be biochemically based at some point in time. So, keep that in mind. It can develop over time just because a person gets stuck in those kinds of thoughts and feelings and behaviors when maybe they weren't born with them, so to speak. All right, so I'm going to use the drums now. So when someone has a true mood disorder, whether it's depression or bipolar, circumstances should not change their mood. So someone who's depressed, their depression, if they're really dealing with a true biochemically based mood disorder, their depression is actually going to dictate their response to things in their life. So let's say someone says to that person, hey, did you hear so-and-so, your mom or your dad or somebody close to you just won the super lottery? Most of us, if we're feeling down that day, we're going to quickly feel very good. Our mood's going to change. Oh, depression is forgotten, But someone who has a true disorder, their disorder is going to dictate their response. So someone who's truly depressed, it's almost like this categorizes or characterizes their mood. Just very slow and lethargic, just very down. They're having trouble getting out of bed, having trouble sleeping, having trouble eating. They're not enjoying the things they normally would enjoy. Maybe they're having some suicidal thoughts. They're having trouble concentrating, all these kinds of things. And if someone says, hey, you just won the lottery, what you would hear this person say is, yeah, well, I don't believe you. Or, oh yeah, well, nothing good ever happens to me. Or they might say, oh, great, now everyone in the world's going to steal all my money from me. Yay. My family's just going to steal me blind. And, I used to think I didn't have any friends. Now I know I'm not going to have any real friends because they're just going to use me. In other words, their depression is dictating their response to the good news. Circumstances, no matter how good, are not going to just snap them out of depression. Okay? A lot of people have been diagnosed with bipolar and or with just depression. And if you look closely at their life, their mood does change significantly with changing circumstances. On the other end, someone who's manic, their mood is, just really upbeat. They're manic. And someone says to them, by the way, so-and-so this person that you're really close to just died. That person is not going to suddenly be, oh my goodness, what? And they're not going to just suddenly start grieving along with everyone else. I'm not going to do it again, but their upbeat mood, because of their manic disorder, is going to dictate their response. And they're going to say something like, oh, wow, oh, gosh, that person, they were so funny. Remember that time we went to the mall and they were joking around with strangers and they were doing all this crazy stuff? Oh my gosh, I got that on video. Isn't that great? Let me get that video out. Let me show it to you. Their manic mood is going to dictate their response. So, with a true disorder, circumstances shouldn't change their response very much at all, not significantly. So, keep that in mind. This is really important to remember, because when people are misdiagnosed, it is often because of the reasons that I have listed today. So, thank you for listening. I hope this is helpful, and appreciate your comments and questions. I'll try to get back to you as soon as I can if you do have any questions on my channel. Thank you.